Research Capacity Building Committee of the Tamil Nadu State Chapter of IPS, and it has been successfully running for many months. Thanks to our supporters under the auspice of President Dr. Ross and other executive committee members. On behalf of RCBC committee, I welcome you all. This platform is unique in the sense that it invites eminent psychiatric researchers outside the Tamil Nadu in India, and we take up one of their journals published for discussion, and also we want them to present something of interesting for our PGs and other members of the Tamil Nadu Psychiatric Society to learn from. So in this we have this is the model that we are running successfully, and it is going well with all our members and then postgraduate students. In this, we have shortlisted Dr. Manjunatha, who is working from NIMHANS as a consultant. His particular publication is taken, and then I request Dr. S.R. Nirmal to introduce our guest speaker and then the journal that we have selected from his publication.
Thank you, Dr. Shivanand. I take pleasure to introduce Dr. Narayana Manjunatha. Sir is additional professor of psychiatry at NIMHANS, and he has extensive publications both in national and international journals, more than around 280 publications. And his interests in research areas also vary, mainly focusing on public psychiatry, primary care, and telepsychiatry. Probably with the COVID and things like that, sir has done a lot of publications in telepsychiatry, including both. He's done a lot of innovations in both teaching and advancement in psychiatry, and few of his innovations are in on-consultation training and extended telepsychiatric on-consultation training. And is not only doing tele-consultations, he's also published on tele aftercare for continuing psychiatric care services. And he's developed a model for clinical schedules in primary care. And he also has area of interest currently he's going to talk about is the rapid testing of intelligence for clinical practice. And his current topic is 1 minute intelligence quotient test. And he's also introduced a lot of new phenomenological terms in psychiatry like delusional procreation syndrome and proxy delusions. And we are waiting. I'm as eager as postgraduates to hear from Dr. Narayana Manjunatha sir directly. And currently, it will be first. It will be a presentation of his article by Dr. Kirtana from JIPMA. She will do a detailed presentation of an article, and we'll wait for other PGs to ask questions or contribute to it, to which she will answer. If not possible, Dr. Manjunatha sir will answer, and then she'll give a critical appraisal of the current article. I welcome you all once again to the RCBC Journal Club. Hand over to Dr. Kirtana.
Thank you, sir. Myself, I'm Dr. Kirtana. I'm a postgraduate resident from JIPMA, and I'll be moving on toward today's Journal Club presentation. So today's journal, it is on the Journal of Psychiatry Research, and it is official scientific publication of the Indian Psychiatric Society, Karnataka chapter. It is an open access and a peer-reviewed journal, and it has both online and print, and it is published quarterly from 2025. So the areas include all aspects of clinical practice and research in psychiatry, including its subspecialties and the allied specialties. The target readers includes the psychiatrist, other medical specialties, and the allied mental health professionals. The editor-in-chief is Dr. Vijay Kumar Habisheta, sir. So moving on to today's methodology article. The article is titled 1 minute intelligence quotient test for point of care grading of the severity of lower intelligence in the patient populations. So the primary author is Dr. Narayana Manjunatha, sir, and the study was conducted in NIMHANS, and it is published in 20th June of 2024. So coming to the introduction, so in psychiatric evaluations, intelligence is assessed during the history taking and the mental status examination. Under MSc, intelligence is assessed in the cognitive function test domain under 4 categories, which include general fund of information, comprehension, arithmetic, and abstract ability. The outcomes are binary, that is either the individual has average or below average intelligence that includes both borderline and the intellectual disabled population. So there is a severity grading for below average or lower intelligence is essential in order to formulate a comprehensive clinical management plan. Currently, for the severity grading, they are referred to formal IQ testing, which is a time-consuming procedure. When we consider the average timeline from the referral to the appointment to the subsequent availability of the reports. Hence, there is a need for an expedited method to assess the severity of lower IQ that will facilitate a prompt execution of comprehensive clinical management during the initial consultation itself without unnecessary delays. So this is specifically important at primary and secondary healthcare centers where formal IQ testing centers are unavailable. So in order to address the need for the rapid and point-of-care clinical assessment for severity of lower intelligence, the 1-minute IQ point-of-care, this test has been formulated, especially for busy clinics to enable a prompt education of patients and their families during the same consultation. So the aim of the study is to compare the clinical concurrence between the 1-minute IQ scores and those from the formally administered IQ test in a case series of around 6 patients. So when we come to learn about this 1-minute IQ test, IQ is an intelligence quotient. It is a numerical representation of individuals' mental age that is related to their actual age. So once we get lower intelligence from history and MSc, we will ask 2 questions to the caregivers. The first question is, compared to the siblings, relatives, or neighbor children, what is the highest age in years in which his or her intelligence has developed? So this gives an idea about their mental age. So if they are uncertain, we can rephrase it in a familiar language and ask about highest abilities like speech, self-care, social interactions, and practical skills in order to gain insights. The second question is to assess their actual age, which we can get from the hospital records or by asking them what is his or her real age in years. So after getting the 2 years, then we use the IQ formula, where that is mental age divided by the actual age into 100 in order to get the IQ. So the actual age should not exceed more than 18 years, even if the age of the individual crosses the 18 years. This is because the mental age will actually increase until 18 years, and after which it stabilizes. The intellectual abilities will stabilize. So even if the individual crosses 18 years, it is the maximum age we can use in actual age calculation is 18 years. So coming to the case series, it is a clinical diagnosis of 6 patients ranged from lower intelligence, like from borderline to mild, moderate, and severe intellectual developmental disorder. The 1-minute IQ scores are recorded during the first and initial consultation, and they are stored in their respective files with a referral for formal IQ testing. The formal IQ testing was done by using Vineland Social Maturity Scale for around 5 patients and Binet-Comet test for around 1 patient. After formal IQ test, the scores from these administered tests, they are gathered in the files for writing this article, so ensuring that the authors remain blinded to these reports. This table shows the comparison of both 1-minute IQ test and the formal IQ test scores. Though the first patient had Binet-Comet test as a formal IQ testing, the rest 5 had Vineland Social Maturity Scale. The visual comparison of scores has been shown that they did not unveil any clinically significant differences. So advantages of this test include the ease of use with a brief 1-minute time frame in the same consultation, and even among illiterate caregivers, so enabling it to integrate with the detailed psychiatric evaluation of the patients. So coming to discussion, it is a 1-minute IQ test is a straightforward, concise, quick, and point-of-care test for assessing the lower IQ severity in the patient population. So this case series, which compared the results from formal IQ test report, they found an acceptable level of clinical concordance between the 2 tests. But the comprehensive analysis of strength and weakness of the 1-minute IQ test is challenging because of lack of point-of-care IQ severity test in the lower IQ populations that has been published in literature till now. The authors suggest using a former classification of mental retardation, classifying it as mild, moderate, and severe as educable, trainable, and dependent MR respectively for counseling purposes to the caregivers. So the strengths of the study include it is innovative and novel point-of-care test for severity grading in lower intelligence patient population with use designed in busy clinics. It enables prompt execution of comprehensive clinical management plans, and it is relevant in primary and secondary healthcare clinics where formal IQ testing centers are not available. So the limitations that are being mentioned in the study include it as a smaller sample size, that is a case series of 6 patients. Statistical significance has not been analyzed, and the focus is on the adult patient population alone. So it is designed for lower IQ population, and it is not intended to calculate IQ in groups with average or above average intelligence. So the study has not systematically studied the comorbidities of lower IQ like epilepsy, autism, cerebral palsy, and the other formal educational attainment. So it is not a substitute for the standard IQ test, especially for the legal or certification purposes, with use restricted to only in prompt clinical management. So conclusion, it is a valuable clinical test to swiftly evaluate the severity of lower IQ in both primary and secondary healthcare settings. The strengths include brevity, clinical relevance, point of care use, and suitability in busy clinics. The future research endeavors should include a multicentric systematic study with a larger sample size encompassing both the children and the adult patient population. And it is essential to assess the reliability, validity, acceptability, and ease of administration and concordance between the 1-minute IQ test and the formal IQ test. Thank you.
Thank you, Dr. Kirtana. Thank you all for the active participation. We'll now proceed to the next session, mental distress and non-psychiatric mental health diagnostic entity. Will be presented by Professor Dr. Narayana Manjunatha, sir. Sir, over to you, sir. Please.
Yeah.
Thank you, sir.
I'll just share my PPT.
Yes, sir.
First, I would like to just tell thanks to Dr. Shivanand Kattimani and IPS Tamil Nadu giving a platform to share our work, and I'm happy to know that many people are interested for 1-minute IQ test. And this is another concept, innovative concepts, which I feel are very relevant in our clinical practice in India as of now. And same concept, more or less, we are utilizing at TeleMANS, National Telemental Health Program. So topic would be mental distress or mental health concern in non-psychiatric mental health conditions. Yeah, next slide. Next slide. Yeah, I think we have read a quote called "I can't see what mind doesn't know." So we have to know many truth about the fundamental truth about the perceptions. So many things are happening in clinical practice. We are not able, we don't have answer for many patients because it is not given in our CTP or OTP. Okay, next slide, please. Yeah, there are many times I could hear that schizophrenia or psychosis is a bread and butter of psychiatrist. So here, another concept I would tell that there is a visible and invisible psychiatric illnesses are there. And in my, no, next slide, go for next slide. And I could observe during my DPM, MD and SR-ship and worked in mental hospital and general hospital. And some kind of thing that there are many patients who used to come and we are not, first and foremost, I learned what is that there is psychiatry is beyond psychosis, very early period of my residency. Then there are many patients who are following in depression, anxiety, somatization spectrum, more than psychosis. That is the next lesson which you could find out. And then when I was SR-ship, I was doing SR, that time I could find out that patient doesn't have psychiatric disorder as per ICD-10 or DSM-4 that point of time. Then why people are consulting us? They are really, they need badly need of some kind of help. Next slide, please. Nil Psychiatry. It is, I would say that it is a diagnosis of convenience for us to give solace for us that, oh, I did my work, there is no psychiatric problem there, but it is not in a psychiatric nosology. And Nil Psychiatry doesn't mean that he is not abnormal. As a medical doctor, we are trained in abnormality and it is easy for us to pick up abnormal than normal. Yeah, next slide, please. Yeah, this is the one book I was as one of the editor here. When I was writing this paper, just editing the chapters in this book, I could make out that there are many people are talking about stress and relating with a psychiatric illness. And one thing which I could observe, that not all the stressors are not having psychiatric disorders at all. That we know by common sense from our MBBS period. Yeah, next slide, please. Yeah, next slide. I'll just go with some vignettes, especially this is the COVID time vignette. 18-year-old girl feeling too stressed about her exams and occasionally having panic attacks when thinking about them. Her parent requested a medical certificate stating that she has a depression and anxiety and a recommendation to repeat her examination later exclusively for her daughter in the college. So they want certificate, medical certificate to say that she has a problem. You give us so that we can request them for a repeat examination. And I have admitted that patient for about 10 days. We did detailed evaluation. We found that she did not have any full-fledged psychiatric disorder. Then we were left wondering what are the diagnosis. Yeah, next slide, please. I'm sure you people are also getting these kind of patients in your clinical practice. Second patient, 22-year-old daughter, was brought by her parents for inpatient care, stating that she has been picking quarrels with her mother every day for last 2 years. After 3 weeks of inpatient evaluation, we could not find out any diagnosable psychiatric disorder, including personality disorder. Please remember, and referred her for family therapy. Yeah, next slide. Next slide, please. Yeah, 42-year-old wife was a doctor. No, just please go back. Next, previous slide. She was a doctor actually, brought by her husband. Husband was also a doctor for inpatient care with a referral from private psychiatrist, stating that she has been demanding a divorce for past year. During the assessment, she reported that she sought divorce as her husband was repeatedly disregarded her wishes, while she has complied with his demand ever since they married. We did not observe any sign and symptoms of psychiatric disorder during her 3 weeks inpatient stay, and she was discharged with no psychiatric diagnosis and recommended couple therapy. Yeah, next slide, please. So uniqueness of these cases, which all three patients, if you can see that we have admitted and evaluated, we were fairly confident that we said they did not have psychiatric disorder. Yeah, again, I am talking what the eye does not see and mind does not know, it doesn't mean that it does not exist. And then if we close up our mind and eye, we will not be able to learn new things in our clinical practices. Yeah, next. So we have just kept the option open to learn something new from these people. These were the post-COVID phenomena. Policymakers and publics have understood the importance of mental health much better than earlier. Self-proclaimed mental health counselors has increased substantially after COVID. Almost equated themselves with as a psychiatrist, and psychiatrists are also getting better attention even among the medical doctors and specialists. Psychiatrists are beginning to see these kind of patient populations in with the self-diagnosed mental illness or proxy-diagnosed mental illness. Proxy means the sense mother or father saying that she has a psychiatric disorder, please evaluate. So these are outer syllabus clinical population. Let's thank to COVID, because these kind of people are getting increased and they need badly help. So what to do? There is hyper awareness about the mental health and demand has increased. How to handle is the question. Next question. Next slide, please. And there are studies in scientific journals which suggest that, for example, National Units of Student survey has done 78% of the people, they reported that they have a mental health problem. And recently, just 1 or 2 weeks back, Japan has done national survey, and there also people have reported 78% of them are anxious. Do you think all of them are having a psychiatric disorder? Definitely not, right? So, one of the popular psychiatrists who is called Simon Wesley, he said, "Stop awareness about mental illness because it is creating more havoc than what we expected." So we don't need people to be more aware. We can't deal with one who already are aware of these kind of things. Thank you. Next. Next slide, please. Next slide, please. And another way, as a reviewer, I am getting an article which saying that, please go back. There are article which is coming for review saying that what it has been done is that they have done some rating scales, some kind of screener research, and they say that 30% of them or 50% of them having psychiatric disorders. So those kind of article are also there, and we know that this is very substantially very high number. It cannot be a reality. So if you just see, there is no confirmatory diagnosis they have made in those kind of articles. Next slide, please. And these are the, please just glance the numbers. There are 22 terminology as used left and right in many public papers, newspaper, journals, and media, and layman people, which all of them are trying to equate as a psychiatric disorder. For example, I have a stress. People equate as a psychiatric distress. I have a stressor in my life, so they are equating that I have a mental illness kind of problem. So, and we are aware that they don't have psychiatric disorders. So, next slide, please. Yes, next slide, next slide. This I already spoke. Next slide, please. Next. Yes. Though what is reality about what I spoke till now is that reality is the way certain distressed about various aspects of their life, leading them to believe that they have a psychiatric disorder causing their unhappiness in their life. I would call them as a distressful population. This raises the following questions. Are we overlooking the undiagnosed conditions? Are these subthreshold conditions? Are these diagnostic or orphan in the clinical our clinics? Are these a risk factor for psychiatric disorder? Perhaps currently no diagnostic category is given in the standard textbooks. So do we need a diagnostic category for these kind of distressful population who are in a diagnostic orphan kind of category, and why and how? Next slide, please. Trend, often psychiatry is equated with mental health. Actually, psychiatry is very small part of mental health. Is my personal opinion. And we as a psychiatrist are also comfortable with it, and often we feel proud of it also. Next slide, please. Next slide. Again, see so many terminology has been used. Next. Yeah, this is the new classification which I try to give in mental health. Go back to previous slide, please. Yeah, just to avoid over medicalizing or psychiatrization of stressor and minor emotional variations, I given a proposal called trichotomy of the mental health, which is Trishul and Trident kind of things, where one end we know the mental illness, another end is a mental wellness. There is an intermediate category called mental distress, this is a huge chunk of people having problem and they want some kind of help. Genuinely, they want help. So this kind of trichotomy I have proposed in 2023 IJP article. Yeah, next slide, please. And if you see the prevalence, we know that around 10 to 15% of the people are having mental illness. Mental distress, I think there is no studies has assessed about it. But my guess is at least 30 to 40% of the general population having mental distress. It is a huge chunk. It's almost 3 times than the real psychiatric disorders. And everybody want to be in wellness kind of. Yeah, next please. Yeah, this slide please. So wellness is a huge area, and I'm not going to talk about it because I'm still trying to learn what is happening in this. Next slide, please. Yeah, mental distress. I'm just trying to talk about mental distress. Neither they are ill nor they're well. They are a distressful population. Another name which you could conveniently say the mental health concerns, and as I already said, 30 to 40% of general population having mental distress. This is my estimations. And there are different category of the stressors on which we can categorize the mental distress, which I'll just tell in next slide. There should be some kind of intervention package and how to manage kind of thing. The core of the mental distress is a stress. Stress, we already know that stress is a risk factor for many non-communicable diseases. Yeah, next slide, please. And stress and human being, we have read a lot about it. Next slide, please. And this also, I think, we know that there are more than 50 common signs and symptoms of stress has been published in the literatures. There are more than 50 signs and symptoms. But yeah, next slide, please. We only know the fight and flight. There are 6 F of the stress. Beyond fight and flight, which is freeze, fluff, friend, and fawn. Yeah, next slide. Next slide, please. I think this all of us we know. Yeah, next slide, please. Yeah, this is one kind of, I think, go back, please. Yeah, there are 4 types of stressor has been published by Attia et al. I found is very interesting for psychiatrists. We should know this. Physical stress, cognitive stress, emotional stress, and behavioral stress. They all are self-explanatory. Behavioral stress are most difficult for a self-diagnosis. Even majority of the doctors who have stress, they themselves are not able to diagnose themselves. Even if you tell that you are under stress, they simply don't believe it. And emotional stress is very tough one to diagnose. And most of the time, I think psychiatrists are the better people to diagnose this emotional stress. Cognitive stress is fairly easy to recognize. Physical stress, yes, more or less we know the things, how it will persist. Yeah, next slide, please. Yeah, these are the categorization of mental distress, and we are using same thing in a telemanus as well. Relationship distress, grief or distress, societal distress, physical illness related distresses, body related distress, lifestyle related distress, workplace related distress, academic stress, sleep related distress, financial distress, and there are many other distress which exist in the human life. Yeah, next slide, please. And why this categorization is important is to make a interventional package, especially in kind of very short kind of counselings, which we will call as a Manasvita. I'll just talk it little later. And intervention package for mental health, since it is a 30 to 40% of people are having, we need to have public health approach more than the clinical approach. So we try to give, so my public health approach should have combination of medical, psychological, as well as social interventions. We need to promote social science research. We need to promote social security programs. Population-based intervention we badly need. That is one of the example is a telemanus. Destigmatization campus and universal access to mental health support, where telemanus is also one of the thing. Community-based social support. Not everybody who is distressed need to meet the psychiatrist and need to meet any mental health professional and need to meet doctors. Okay, we should encourage them to talk to their friends, family member. They can give a better help in many of the people. And employees are wellness programs. Life skill as a mental health promotional program. One of the things which we are doing is Yuva Spandana. Yeah, next slide, please. And this is an individual level intervention which we can utilize when they come for help at clinics. Self-care we can advise. Community care, we should encourage them to talk to their friends, family, neighbor, wherever possible. They need not to depend on the medical setups exclusively. And primary care is one of the example is a telemanus counselor who has a different cadre of people has come in the picture for telemanus who can provide the help for these kind of distresses. Specialized care is only needed for intensive care people who are psychiatrists, psychologists, or social care specialists can be available. This is a stepped up care model kind of things. Yeah, next slide, please. And primary care counselor, as I said, they can give a generic counseling. Social care, more of social care intervention at first point of care. And as I said, they should give a very low intensity, culturally adapted single session or 1 or 2 or 3 sessions first contact counselings to reduce the distress. And actually there is a huge demand for in India people. Many sessions the people don't come, they just want 1 or 2 sessions for their questions or their stress in the life, which we fondly call as a manasvita. In the term is a Sanskrit term which means hope. Here in this 1 or 2 session, what is the important target which we have? Inducing the hope in the individual who are distressful. That is what we do here. Thank you. Next. Yeah, then coming to specialist care, where distress-oriented psychotherapy we badly need rather than illness-based psychotherapy. Whatever we read in psychiatry is more of illness-based psychotherapy. We have to move away from illness-based psychotherapy to handle distressful population, which is we badly need this kind of psychotherapy, and we need social intervention for mental distress. And what is the role of psychiatrists in this? And the role of the psychiatrist to assess these kind of help seekers, rule out the possible psychiatric disorder, and refer to appropriate psychological or social intervention whenever it is needed. And what is the role of pharmacological management here? Personally, we don't want to recommend pharmacotherapy as first-line treatment. However, symptomatic pharmacotherapy, which we know from our MBBS profile, where many illness we can use medication on a symptom basis for a very short period. In generally, long-term pharmacotherapy is not advised in mental distress until unless it is converted into mental illness. Next slide, please. And we have proposed the criteria for diagnosis of mental distress. This is for academic discussion. This is for a further research, how to do the research. And for example, further epidemiological data, if you want to collect, we need some kind of diagnostic category, right? So we formulated this kind of diagnosis where 8 points has been made. Where one of the crucial point is that there is a subject experience of negative emotional states, where I already spoke about emotional stress, one kind of category, where different kind of emotions, feelings are there: anxiety, depression, stress, fear, sadness, or emotional discomfort, worry, agony, irritability. Many people are irritable during the stressful period. But when you say that you are under stress, they don't diagnose, they don't agree with us. And then at least one symptoms from other remaining 3 types of stress, from physical or behavioral, cognitive. This is the crux. Third point is that how to differentiate from psychiatric disorder with mental distress is that the experience of stress response is proportionate to the manageable level. That means it is not excessive stress. And remember, for example, person who is going for exam, he will have some amount of stress, right? And he could manage that. And only after exam that will come out, he will come out of it. So we need not to call as a psychiatric disorder because it is not excessive, it is a proportionate to manageable level, and remain control. And there is a nil and negligible disruptions of biosociooccupational dysfunctions. Please note that symptoms and signs are varies from person to person, and source of stress, at least one source of stress are in the life should be there. And duration need not be a specific, it may be brief or prolonged, anything. And we have to exclude the concurrent mental illness that could have give an explanation for presence of the the stressor period and associated with the stressor responses. So this is the proposed diagnostic criteria which we have given for to diagnose mental distress. Yeah, next slide, please. Yeah, okay. Another way of categorizing mental distress is based on the duration: acute distress, chronic distress, episodically acute distress. So episodically acute distress could be just recall your MBBS period. Whenever you are going for exam, there will be a distress. So it is episodic. So that kind of meaning which we could make out. Next slide, please. Yeah, what is the course, remission, conversion, prognosis? Actually, we don't have any data on this thing because it is just formulated. Most of the mental distress are transient. We could think in that way: transient and self-limiting condition. Many of them don't need any outside help. Many of them can manage self-care. Many of them they need help from the family kind of thing. And life course of the mental distress, equivalent condition or recurrence has been not explored till date. But some of the research says every human being typically faces at least average 2 stressful life events within the past year, and around 10 events in their lifetime. So every human being at least he has to go through 10 life stressors in the life. So this is the thing. This actually, interestingly, this is Indian study. Psychiatrical in network. Next slide. Next slide. Yeah, when we propose mental distress as a category, then already there are many ICD-10 diagnoses which is there, is under threat. And whether we to diagnose or not, these are the illness. Mixed anxiety depressive category, is it a real psychiatric disorder? We have to think twice. Dysthymia, is it really psychiatric disorder? We have to think twice. Mild to moderate depressive disorder, adjustment disorder, acute stress disorder, suicidal ideations, plan, attempt, personality disorder, even some kind of PTSD. All these categories will come for a kind of doubt whether to add as a psychiatric disorder or mental distress. Yeah, next slide, please. Future research, I think more than psychiatry, we need to go to do the research about distressful population, and we need some kind of wellness research also. And this will broaden the spectrum of the psychiatry outside the psychiatry. And we need epidemiological studies in mental distress, and we need to validate the diagnostic criteria and terminology which we use as wellness, distress, illness, interventional packages. We have to work it out very, very methodologically, which is relevant for our people. And Manaswita, as I said, we have to move away from the illness-based psychotherapy to distress-based psychotherapy. And badly needed in India is single session or 2 or 3 session counseling is badly needed. Thank you. Next slide. Thank you very much. And this, I think this year I've just produced the YouTube videos. And this mental distress category, I just produced some small videos and I put it. If anybody is interested, can go through that. Thank you very much.
Okay. The Professor Manjunatha sir for graciously accepting our invitation and delivered a wonderful presentation as well as answered the questions with patience. I thank all the Tamil Nadu IPS RCB members who actively participated in this program. I would like to thank Dr. Kirtana, the postgraduate from JIPMER, who has presented well and tried to answer most of the questions. I would like to thank all the postgraduates who joined this program and answered or asked the questions, whatever you had. I would like to thank all the faculties and other members who have joined. I would like to thank the supporting team for being with us. Thank you all. Thank you.
Thank you very much. Thank you, Dr.
Yes, sir.
Kirtana.
Thank you,
Thank
sir.
you, sir.
Thank you.
Thank you, sir.